Okay, for those who just joined us online, my name is David Kong, and thank you very much for joining us this morning. Phil has mentioned to me I've got exactly 20 minutes and no more to finish this, or else he's going to put me out. So I'm going to whip through this morning. Look, what I started to do, I thought I chose this paper for a couple of reasons. It'll be a bit more obvious a bit later on. But to start off with, the article for today is very much taken from CID. And really, if you look at the impact factor, which I got from the website, it's kind of one of those journals that up in the ID ranking. It's one of those journals that you really, really want to get the article in. So this article is about a hospital-wide rollout of AMS using the stat wage randomized trial. Let's see. Does it work, Phil? Or if I hit the...
Just the arrow down.
It's not working. There goes my... Okay. Right. The reason why the author's justification of doing a stepwise stat wage randomized trial is that their argument is that based on the work by the Cochrane review by Peter Davey and his group in about a couple of years ago, there's really a lot of absence of RCT or randomized trial into AMS to give it some more robust quality studies. And the lack of controlled trials is also further highlighted in a recent systematic review in ICHI that was published sometime last year. And again, there's the same principles and concept behind that. Essentially, for those, I hope people have had a chance to at least glance through the article. What the authors are trying to do is pretty much trying to translate the work that they've done in ICU to the rest of the hospital. And the work that ICU has been published in about 2012. And I'll come to exactly the methodology a little bit later. This is driving me insane. I have click. Okay, here we go. What I thought I'll do is to try to take a bit of a different slant, is to share some of our approach towards running a journal club, for which we've done at our campus. And one of the things you would do quite often when you pick up a paper is you're expected to read through it, pick it up, and tear it to bits and pieces. The difficulty quite often is, are you tearing the bits and pieces in the right way to give you some understanding of what the paper actually means? So in the area of evidence-based medicine, you can find that there are critical appraisal tools that are available. One of the more comprehensive sites for critical appraisal tools is the one in University of South Australia, which you can access the tool. And as you access it, the site, it actually gives you a series of tools, which is down here. Like, whichever articles that you are trying to appraise, you can try to go in and pick up. And let's say if it's RCT, it will tell you these are the number of different tools that's available that you can go and pick up to help you to go through the particular article of interest. Another site that people tend to use quite a fair bit is the Critical Appraisal Tool Skills Program, which is based at Oxford, which is led by Professor Sir Gray. And this site actually, again, similar to the South Australian sites, if you do go in, they have a series of checklists that you can actually pull up, and you can actually go through the checklist and as you read the article to see whether it makes any sense or not. And for the purpose of today, for all things, I chose a stat wage randomized. They don't have a stat wage randomized tool specifically for that. They have a RCT randomized control trial tool. And I thought, look, that's probably the closest I can find the tool in terms of trying to use this. So I'm going to use the RCT control tool from CAS to take people through the journal club, the article as it is. So usually what you do is you first assess the first question. Does the study actually ask a clearly focused question? things like, did it tell you a bit about the populations and the interventions and the outcome that were considered? If you go through the article, you probably say yes, it did. It's a bit of population, intervention, and outcomes. But when I actually go through the article at the front and introduction to find out exactly what they are trying to do, all this is this big statement: you want to rigorously evaluate the impact of AMS. From my perspective, kind of not really not really as clear as I think it could have been. At this point, I think one of the things, to be fair to the authors as well, it's quite easy for us to criticize a journal article from where you're standing, without understanding the reason why they're writing. They have editorial restrictions and so on. So sometimes we need to be fair to them, take the criticism with a bit of grain of salt. And the second thing that they ask is, in using the CAPS tool, is it a randomized controlled trial? Yeah, kind of, yes. It's it's not a parallel control. It's kind of, they've got a control period. They randomize the wards that needs to be to implement their AMS in a sequential manner, with the statistician getting involved, and essentially they use a stat-based randomized trial. So yeah, sure, we can really say something about it. So essentially, what do they actually do? The whole idea behind the study is they randomize the trial that's going to receive the ward that's going to receive the intervention, and each ward will get an educational session about 1 week before the intervention. It's really not very clear as in how long the education continues, so it's just a once-off thing. It sounds like a once-off thing. And then they got a pharmacist to review the antibiotic, the targeted antibiotic. Notice that they have an intervention in each ward, but not all patients are getting intervened. It's only a selected group of antibiotics of interest that gets reviewed at day 3 or day 10 by one pharmacist. And that process raised the question, is there an issue of biasness in terms of the pharmacist assessing the level of experience the person that's doing the work? It's not very clear, but you can kind of suspect it's probably someone with some experience in it. Other questions that can be raised is, ward that's with a bit of high turnover, sometimes is day 3 review or day 10 review probably the most appropriate. Bearing in mind what the authors tried to do was essentially just take whatever they did in ICU and just whack it on to the rest of the hospital. And for cases that has been identified by the pharmacist requiring intervention, then there is a consultation with an ID specialist, and recommendation is made to the unit, and it's up to the managing unit to decide or reject the recommendation. So that's really what the intervention is all about. At this point in time, look, a lot, depending on who is in where you are, and most hospitals, and how AMS is working, has been implemented. There's also an article which I picked up recently that came up from CID last year about optimizing research method use in evaluation of AMS stewardship. It's not a bad article. I thought I would bring it to people's attention because this article sort of take you through the process of thinking about the methods that you want to use to evaluate your AMS. Thus gives you some articulated points to think about in terms of the study design. Yeah, you need to think about, when you're designing the study, what you need to think, some key points you need to think about. And when it comes to your data analysis, what are some of the key points you need to analyze, consider. And also it gives you a bit of, they do have a reasonably nice table, I think, a brief summary about the different types of studies that you can do in the AMS arena, their strengths, their weaknesses, and so on, and how you measure it. So it's quite a nice article to read through if people want to find out a little bit more about the methods. So back to the thing using the CAP study, the article, was it a randomized controlled trial? Yeah, we think it is. Is it worth reading? Yep, at this point, it's probably worth reading. So you kind of continue on. And the next article is, were the participants appropriately allocated to the intervention and control group? To some extent, you can't really tell. This is, the CAS tool is very useful for RCT, where it's a patient that can randomize. Whereas in here, it's kind of like cluster, where it's the ward or the service that get randomized. But what you can say is that really not all patients get reviewed in the intervention arm, and there are minimal data on patient demographics that they have actually tried to collect. There's not much information that's out there. So were the staff blinded? You probably not, because really you can't blind something like an AMS thing. People will know anyway. The other aspects which I think I didn't cover is was that which randomized the right study to do. It probably is. You can't. Ethically you can't randomize one patient getting a service and the other not getting one. You want to go time series because we lack the ability to randomize. So how do we fit in a randomized control study? So that's they ask the stat ratio is probably the right thing to do. So it's probably the right methodology in that sense. So were all participants entered and accounted for at its conclusion? Yes, they were entered and accounted for in the conclusion, in part as given in the table, where they will tell you how many patients were in the control period, how many patients were in the intervention period. This is more editorial thing. I don't quite understand why you need to use the word unique patient. I have no idea, and they would be able to clearly articulate how many got admitted and how many of the admission occurred during the control and how many during the intervention period. So they did take into account the whole process at a larger level. If you use a tool, you say, will all the participants in all groups follow up and data collected the same way? Yes, they did, and that's reasonable. And did the study have enough participants to minimize the chance of play? Really, one can't tell. There is no sample size calculation. Nothing has been given about how they estimate. All they did was, we're going to do it over this period. Whatever comes, we take it along. So is that the right way to do the study? Did they give you the power that you need to justify for your results? You can't really tell from that study. So comes to the question, how are the results presented and what is the main results? And the thing you can consider in the paper is, the results presented as a proportion of people, those who have, or as a experiencing an outcome or risk of measurement. How large is the size of the results, how meaningful it is, and how would you sum up the bottom line of the trial in one sentence? If you go through the results section, we can probably say that, look, roughly 20% of the patients are reviewed during the study period by the intervention period by the AMS pharmacists, with about 50% of those requiring intervention. It is a large group of patients, about roughly 20,000, but really the proportion that actually got the service was minimal, it was low. You have no idea whether they reviewed the orders in day 3 or day 10, but you would suspect most occurred in day 3. Given what they are trying to say later on, so it's not very clear. And they had reasons for why they said that of the orders that were reviewed, and these are the different units who had targeted antibiotics prescribed and that were reviewed during the intervention period. And there's this column here is when the recommended changes occur, where roughly about 50% of all that was reviewed resulted in changes, and roughly about all 80%, roughly 80% of all recommendations were accepted. This is a very big picture view, but what's lost in between the line is why were those rejected? It's not clear in the paper, the reason, and sometimes it's good to know because that helps you to think about how you want to change and modify the program next time around. So, and if you look at the results of further, they say, look, for all patients receiving interventions, they did see a reduction in the duration of therapy for those when they collectively look into that. But that is only for those who receive the interventions, receiving intervention. But if they collectively look at the whole hospitals, all the wards involved, it actually makes no difference at all. Again, this table shows the different clinical service. It shows the control period in terms of the duration of treatment, and it shows the intervention period and the duration of therapy. And you can see those which are highlighted in red are some of the units in which statistically there was a significant difference noted in terms of their duration of treatment. It does appear that targeted AMS intervention in this unit on the specific range of group of antibiotics kind of did make a difference in terms of the duration of treatment. What's not clear is for some that there is no difference. Is there a reason why? Could it be a statistical reason? We don't know. It's unclear from that setting. And they then went on to say we did a fair bit of secondary outcome to look at a lot of things, looking at drug use across non-targeted, the range of antibiotics that are not within their scope of intervention, the total, everything all lumped together. Looking at antimicrobial costs and all their secondary reviews absolutely did not make this. It was a short paragraph that says, look, didn't make any difference at all to all the secondary outcomes. But it's quite interestingly, if you really go through the table in a bit more in-depth manner, if you look at the medium length of stay, it does appear to some extent it did. The intervention actually increased the length of stay statistically in the for those patients who received the intervention, the review, and overall for all admitted patients combined, it didn't. That was not eluded, was not mentioned, was not discussed anywhere in the paper at all, just tucked hidden away. Question size, sample size, again, issues come in. And in that study, they were talking about this is a 12-month study trying to intervene, looking at changes in antibiotic resistant organism or C. diffs, because from the experience in ICU, raises the question is were they targeting the right organism? Did they allow enough time for change from that perspective? So the question now comes to, you've seen the results, you kind of tag to shreds to some extent. So how precise are these results? Is it enough to make a decision? Is a p-value reported? Yes. How useful it is, it's a bit of a debate. And if you look a little bit into the results and the way it's writing, and now some of these comments I have made can be a little bit editorial. So as in the discussion, this was a large statistically significant reduction in targeted antimicrobial use among patients meeting indication for our 3-day audit and feedback. Conveniently, the 10-day has disappeared somewhere. We don't know exactly what happened. So did the result say anything about day 3 or day 10? And sometimes the result suggests high suggestion and acceptance rate is 50%. They've only 50% of the antibiotics require intervention. Is that really high? Suggestion rate, really, they don't do much. Acceptance rate, granted high, is 80% when they make a recommendation. So that's some of my thoughts. Other aspects is they talk about abbreviated antibiotics, where they mention a little bit about the reason why we don't see what we don't see is because most of the patients are on very short courses of antibiotics, but they don't actually give you any data about short courses to really appreciate and evaluate the paper. And what is an abbreviation means? Is it 5 days? Is it 6 days? Is it 4 days? Nobody knows. And they say that most of them are on median of 4 days, and presumably that's really the patients who are affected in those what as their length of stay. Other aspects is that they mention a little bit of the major strength of this study is it's a lot of patients. Granted, there is a lot of patients, but if you really dice down how many was receiving and what did it work, roughly 1 in 5 would have got the service. And part of the discussion, the main program objective is the main, I emphasize the word the main. Program objective is to reduce inpatient antimicrobial use, to reduce antibiotic costs and complication funding. For me, I guess, reduce consumption and reduce costs seems to be the main thing, but antibiotic cost is pretty much the secondary outcome from their perspective. And they talk about complication. There isn't really any complication being mentioned. And it could be, I didn't mention it because we didn't see any unintended consequences. And in the secondary outcome, there was no difference in mortality. So it's good in the sense it didn't change anything. It's mentioned that it was successfully transitioned. I guess if you measure the acceptance and so on, yes. But how do we know how well it's accepted by the end user? What do people think about it? It's not quite there. There's just no data about that. So it comes down to really all the important outcomes considered so the results can be applied. When I get to this point, after reading the article and saying it was published in CID, I might be a bit cynical on this. Did we really learn anything we don't know? probably teach me a few things. We did know that it did confirm that intervention, having someone make a difference, it does.
Having it in a single site means that there would have been a morphal effect of moving between the sites. This was a major criticism of some of the treaty group, that you can't do an intervention like this, a true stepped reach in a single site, because the same doctors move across the hospital.
It's a bit hard to hide.
And I think they continue to miss the point about appropriateness and sort of focus on DDDs, and we saw that at ECAC. They haven't moved on yet to the next step, which is the qualitative aspect.
That's right.
Of stewardship.
That's right. So did it really present anything new? It probably says it doesn't cause any harm. It probably says that if you're trying to use an intervention to influence other practices around, it doesn't make anything, it doesn't do anything.
I think the problem is you can't define stewardship as just that. It's a whole lot of policy down to feedback. You don't get enough granular information about what the service really is about.
No, I guess one of the reason why I chose this article in part is it's just a nice way sometimes to see how interesting articles gets into certain journals of what you think they should be, and once you start going through and using the tools, and using the tools to really help you cut through is quite a useful practice at times.
I guess all of us is probably got to the environment to do if we're going to look at it, but I think the real way should probably be across across institutions.
Yeah, you probably need to be across that. All right, I'll stop it here.
You see no questions? Okay, good. Is that good start?
No.
No? Yeah.
We're right?
Yep.
Okay. Noleen Bennett, and I'm going to talk about antimicrobial stewardship in aged care services. I'm going to talk quite quickly because I want to allow some time to answer the question, how do we define, encourage, measure and monitor quality in aged care services in relation to antimicrobial stewardship? To help us answer that, I'm going to outline briefly 4 sections: Aged Care National Antimicrobial Prescribing Survey, the CDC core elements of antibiotic stewardship for nursing homes, pilot quality indicators for aged care program, and the Australian Aged Care Quality Agency. So if I start with the pilot aged care NAPS, the data collection for this was recently completed, and there will be a report available soonish. 186 facilities participated, all states were represented, no territories. The majority were from Victoria, 69.9%. All remoteness and all funding types were represented. On the survey day, 11.3% of residents were receiving one or more antimicrobial. Data was obtained on 975 prescriptions. The most commonly prescribed antimicrobial was cefalexin, and note topical antimicrobials featured strongly. Antimicrobial prescriptions, 32% did not have a reason documented in the history. 65% did not have a review or stop date documented. 31% were started greater than 6 months ago. Of these, 98% did not have a plan for review. 23% were for prevention of infection, and 1 in 5 were for residents that did not have any signs or symptoms of infection. Indications, note that 17.5% were for unspecified skin, soft tissue or mucosal reasons, and 5.5% were for an unknown reason. Okay, the CDC antimicrobial stewardship core elements. In 2015, the core elements of antibiotic stewardship for nursing homes was released. This was based on part on the 2014 core elements of hospital antibiotic stewardship programs. In Australia, we do not have similar core elements or guidelines. I'm pleased to say, though, at the very least, there'll be a chapter in the next version of the Commission's 2011 Antimicrobial Stewardship in Hospitals on aged care. The 7 core elements are represented in both of those USA publications. Obviously, the most relevant to the aged care NAPS is the tracking and reporting. For each of the core elements, I've listed first in red the nursing home summary. The hospital summary is in black. It's just for you at a glance to make a comparison. So for leadership commitment, the aim was to demonstrate support and commitment to safe and appropriate antibiotic use. Accountability is to identify a physician, nursing and pharmacy leads responsible for promoting and overseeing antimicrobial stewardship activities. Drug expertise is to establish access to consultant pharmacists or other individuals with experience or training in antimicrobial stewardship. Action is to implement at least one policy or practice to improve antibiotic use. Tracking is to monitor at least one process measure of antibiotic use and at least one outcome from antibiotic use. Now, if I just pause here for a moment, on the tracking checklist, for those facilities participating in the aged care NAPS, when asked, does your facility monitor one or more measures of antibiotic use, they would be able to tick those practices highlighted in red. When asked, does your facility monitor one or more outcomes of antibiotic use, it's not entirely accurate for them, and these are the facilities that are participating in the aged care NAPS, it's not entirely accurate for them to tick that monitor rates of C. difficile infection and that they monitor rates of antibiotic-resistant organisms, even though they're collecting information. That is, after talking to some epidemiologists yesterday, is that the aged care NAPS is a point prevalence survey, and even if a series of point prevalence studies are done, rates are not being monitored because there's no time measurement. Reporting, the aim is to provide regular feedback on antibiotic use and resistance to prescribing clinicians, nursing staff and other relevant staff. And if we look at the checklist, for those facilities participating in the aged care NAPS, when asked, does your facility provide facility reports on antibiotic use and outcomes with clinical providers and nursing staff, they are able to tick that there's measures of antibiotic use at the facility and measures of outcomes related to antibiotic use. The 7th component, the aim is to provide resources to clinicians, nursing staff, residents and families about antibiotic resistance and opportunities for improving antibiotic use. Okay, so the aged care quality indicators. In 2015, there's a national pilot program that was initiated by the Commonwealth Department. It was commenced in May 2015. It was voluntary. It was complementary to, but not part of, the aged care accreditation. Over time, the post-pilot quality indicator results will be published on the My Aged Care website. This is the website that consumers are being encouraged to access in choosing aged care services. The clinical indicators that they used as part of this pilot, and I might add there's not a report yet, but there will be. The clinical indicators were pressure injuries, unplanned weight loss, physical restraint, and quality of life consumer experience. These initial clinical indicators, the first 3, are based on extensive international and Victorian public facility experience. The quality of life consumer experience indicators are being developed in consultation with stakeholders. So if I talk about the aged care quality agent, just remember that at the end of this session, I'm going to be asking you to answer that question. How do we define, encourage, measure and monitor quality in aged care services in relation to antimicrobial stewardship? So actually I'm going to jump ahead. These slides are just out of order, but the Aged Care Quality Agent was formerly the Aged Care Standards and Accreditation Agency. The Aged Care Act 1997 requires that approved facilities providers comply with accreditation standards. Since 1999, the Quality Agent has assessed facilities against these standards, and in 2015, almost all of the facilities meet the standards. In 1999, when they first started, about a third of them failed, and many of them had to close as a consequence. I'll just go back to the previous. So there are 4 standards and 44 outcomes. The standards: management systems, staffing and organisational development, health and personal care, care recipient lifestyle, physical environment and safe systems. Many of the outcomes are relevant to antimicrobial stewardship, but I just want to highlight 2: medication management and infection control. So medication management, the expected outcome is care recipients' medication is managed safely and correctly. And these are the results that an auditor would be looking for that the facility has met when they visit. The visits can be planned or unannounced. Infection control, the expected outcome is that they have an effective infection control program, and there are 4 results that they are looking to measure. But the accreditation is currently under review. Hooray. This discussion page, let's talk about quality, developing a shared understanding of quality in aged care services. Unfortunately, the feedback for it is closed. A report will be available on the agency's website in November. But if I could just highlight a few things in the discussion paper, and one is that when they refer to aged care services, it's more than residential aged care facilities. There's the community, and there's a strong emphasis now on home care, where they are distributing medication, Commonwealth Home Support Program, and the National Aboriginal and Torres Strait Islander Flexible Aged Care Program. So again, it's more than residential aged care facilities. The thing to remember too in aged care is that whilst we, for the most part, work to the clinical model, there are other perspectives that influence quality in aged care. And that, of course, the social model in aged care facilities, it's their home. Organisational excellence framework, for the most, that these facilities are not for profit or private, and the bottom line results count. And then there's the risk management system, preventing adverse outcomes such as falls. In the discussion paper, there were some themes. In the literature, there's a lot of emphasis now in aged care that putting consumers front and centre. And there's the Commonwealth have put out a statement as such, aged care statement of principles, that just outlines that consumers are centre and front. The other themes: safety is essential but not enough, integration across the aged care experience, so somebody that starts in the home, that their care is consistent when they might end up in an aged care facility. A quality culture that encourages excellence, that these minimum standards to date that they've been reaching are not enough, and leadership in innovation. So let's come back to the question. How do we define, encourage, measure and monitor quality in aged care services in relation to antimicrobial stewardship? For those off-site, you're lucky. Those here today, you're not leaving until we answer this question. But if I can throw up a few more questions. Do we extend what the National Centre for Antimicrobial Stewardship is doing to all aged care services, aside from residential aged care facilities? Do we extend our antimicrobial stewardship activities aside from the aged care NAPs? Do we collaborate with the quality indicators for aged care program? Do we collaborate with the Aged Care Quality Agency? And do we collaborate with consumer groups, for example, COTA, which formerly they were referred to the Council for the Ageing? It is important that we get answers, because there's some representatives from the National Centre for Antimicrobial Stewardship that's actually soon going to be meeting with Michael Culham from the Commonwealth Department of Health. Now, I don't know Michael, but I know he's important because he's high up on the organisational chart. He reports to the Deputy Secretary in Ageing and Aged Care, who then, of course, reports to the Secretary. He's responsible for access, quality and compliance, and he, in fact, is coordinating the quality in aged care review. I see this as a really important opportunity for the National Centre for Antimicrobial Stewardship having a say in aged care. So if I go back and open up to the answers or discussion around the questions. I'll let
and those online can type in.
Okay.
Noleen, I've got a question. The aged care quality agency, I can't remember, are they government or are they private?
You know when the government says you're independent, but we fund you? Yeah, so they would argue they're independent, but they are funded by the government. Do people think we should extend to all aged care services?
I can't see how you can say no. I think it's a yes to all of those dot points, in fact, because I think that's what primary care is. It's all those areas, and you can't just go to one section, not all the others.
Yeah. In fact, the greatest growth area is in the home care, not their aged care facilities. Whilst Australians, the numbers of older Australians is increasing dramatically, as far as services go, it's home care. Okay, what about extending our antimicrobial stewardship activities into education?
Again, that's a no-brainer.
Yep.
I think we say over and over and over that ACNAPS just collects the data, but we've done nothing unless we act on it. And I think what we're trying to achieve is to uncover the areas where we can improve or change. And in order to do that, I suspect we may have to go in with some sort of system-based approach. You know, it may be that, for example, the one that you highlighted that I think we all groaned when we saw was that 31% of antibiotics had been started 6 months ago, and the majority of them didn't have a plan for any review. You know, if we could put in a system that sort of put in a standardised period for review, so that we sort of at least in, you know, I like the term mindful prescribing, but people actually think about what these patients are being given, and can we justify it? Do they still need it? Is it causing any harm? And is it still the right thing for them? You know, it might have been the right thing 6 months ago, but maybe it's not now. And so I would think that we have to strive to go beyond. ACNAPS is just the start. It's just the start of showing us where we need to focus our attention.
I agree.
My perspective on it.
Yep. I have a question online here. From Fiona Dukas, and I'm assuming you're from, I know from the NPS. Does the NPS Medicines Use Review Aged Care have a role here? I'm going to say yes. The audience here?
Yeah,
yes.
Absolutely. Again, though, it's about focusing so that we can draw attention to which aspects of that medication review need the most attention.
Targeted.
How can we put a system in place so that we're dealing with it before it happens? You know, we're intervening earlier. So absolutely, as many people paying attention to this as possible.
Absolutely, I agree. And Fiona, sorry, yes, from Concord Hospital. Can see that. Thank you.
Can I ask a question? Because this will help me, because we're kind of going through this right now. How do you measure quality in aged care? And there is some criticism in the literature that antimicrobial stewardship programs, strictly speaking, ought to be measured on the basis of those rates of multi-drug resistant organisms,
the outcomes,
C. difficile infections.
Yep.
And the criticism is that we justify ourselves with all these other endpoints. And so when designing what I'm going to be doing in aged care, I'm trying to get my head around all of that. And so I just want some opinions on these other endpoints, on whether or not it should just be a strict measure of the rates of multi-drug resistant organism infection, because I think that there's other measures of care, and I think AMS can improve other measures of care. But again, in the literature, some of the criticism is that strictly speaking, it ought to be measured on the rates of multi-drug resistant organism infection and C. difficile.
Do you think that's partly a reflection of the bigger problems that they've had with those things in other countries than we've had here? That might be a...
It could be. I would argue that we can't ignore the transmission, as you know, AMS has not a lot to do with transmission, and that's a big reason why we have MDR pathogens and C. diff in aged care too. So I don't think AMS can wholly be measured by that.
No.
And I think I completely agree with you that it's got to be more than that. And As an example, we know that polypharmacy causes harm in elderly people if you're giving them a drug that they don't need. We could be causing a lot of other adverse consequences apart from just changing the flora in the local ecology. You know, thinking about the harm we might be doing that individually.
And isn't some of that be better for action than actually just measuring rates? If you're just measuring rates of MROs and CD, if it's kind of harder to target where your actions are than if you're measuring some of the other things on the floor.
I think the other issue is also there's lots of community quiet organisms in CD in particular nowadays that can't necessarily be associated with antimicrobial use in these facilities too. And it's really hard to, at the moment, to split that community quiet apart.
They talk about like lowering the use of antibiotics and all those other things as intermediate endpoints, whereas, you know, the final endpoint ought to be that, the rate of transmission. And so, like, I'm still working through it because I believe there's other measures of quality than that. But just there's some of that criticism.
Look, I think historically, the reason why AMS came into prominence historically was this fear of resistance, and that's kind of put it in the limelight. But the reality is when you look at AMS and antibiotic use, it's the same when you use an antibiotic. It's the way you use a medicine which has an impact on the patient, which means it's the quality of the healthcare that you give to the patient. So whilst historically it's because of resistance issues that's kind of pushed AMS into the forefront of the limelight, as you look into AMS over the years, to some extent I think I would say the trend to some extent is changing, where it's not only being viewed as containment or resistance, but people use that as an excuse to get things done because that causes fear. There's the national agenda, but it is also another avenue for quality improvement in patient care. And the difficulty I think with AMS sometimes in quality care of patients is that if you want to measure patient outcome, it is quite difficult. Can you measure your AMS prevent death in a hospital? It's a hard thing to measure because of all the confounding issues. So those are the harder, the really hard outcome of a quality of care. Antibiotics and AMS are a little bit difficult to deal with. And that's why if you go to most of the reviews, 7 reviews of papers that comes out in recent days, most of the measures tend to focus along on the softer ones like dollar and cents of cost, which is easily captured and so on. So that's changing.
All this move to patient-centred care, measuring MROs and CDF is not really focusing on patient-centred care, whereas a lot of those other ones are looking at the harm caused by the polypharmacy, and so there's that argument as well.
I think we're at the stage just on the patient-centred care where residents residents not yet know about this. You know, their focus is on a lot of other things. If you go into aged care services, like that, you know, I'll still be able to do all the activities that I love doing. You know, so we're sort of way behind even in educating these consumers about potential aged care issues. That's the first thing to say. The other thing I'd like to add is on the outcomes, I appreciate that's not the only measurement. However, I wouldn't mind knowing what sort of rates there are for 1,000 reasons, because I'm often in forums where I hear, you know, and as for those aged care facilities, oh my God, you know, and we don't really know our rates in our Australian aged care facilities. So I appreciate that it's not just about antimicrobial stewardship when you're talking about these multi-drug resistant organisms, but I just think I'd like to know what the rates are.
And I think that's a crucial point. It's really important to know what that data is, but it's also important to be careful how that data is used.
Correct.
Correct. If it gets misused, the quality measures for purposes was never intended that it's going to open up to gaming. So it's really important that surveillance activity is set up properly.
Yep, I agree. Now, is there any more questions online or in the room? Have I used my 20 minutes, Phil?
It'll be dogged out.
Okay, if anyone has any more answers and wants to contact us before that meeting, it would be much appreciated. Thank you.
Okay, thanks Noleen and David. And just a reminder to everybody that our last monthly meeting for the year is on Wednesday the 9th of December. Thank you and see you then.
Yeah, I know.